Hi, I'm Julina Onkasawan. I'm an Associate Professor of Adult and Pediatric Laryngology at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. In this module, we will be reviewing how to perform and interpret laryngeal ultrasound for the diagnosis of vocal fold mobility. Vocal fold movement impairment in infants and children may cause stridor, a weak voice or cry, feeding difficulties, aspiration, and impaired pulmonary clearance. Most commonly, vocal fold movement impairment is evaluated via flexible nasolaryngoscopy. However, awake flexible nasolaryngoscopy in infants and children can be challenging because they move a lot. So the excessive movement, floppy supraglottic structures or secretions can obscure visualization of the vocal folds. In addition, awake flexible nasolaryngoscopy can cause significant changes in physiologic parameters such as blood pressure, pulse, and oxygenation, which can be particularly concerning in vulnerable populations such as children with congenital heart disease. Finally, the coughing and crying stimulated during the exam can be potentially aerosol generating. Laryngeal ultrasound has been found to be an alternative, less invasive means of evaluating vocal fold mobility in infants and children, with substantial agreement with traditional flexible laryngoscopy. An important limitation to keep in mind, however, is that laryngeal ultrasound cannot be a substitute for a complete airway examination, especially when evaluating for stridor or respiratory distress. In addition, laryngeal ultrasound cannot be used to evaluate vocal fold closure patterns. The objectives of this module are 1. To describe the procedural technique for laryngeal ultrasound. 2. To qualitatively diagnose vocal fold movement impairment on laryngeal ultrasound. And 3. To measure vocal fold-arytenoid angles on laryngeal ultrasound. How this module works. First, view the didactic presentation at the beginning of the module. Then, complete the 20 case modules that follow. You can choose to participate just qualitatively in the interpretation of the laryngeal ultrasound. However, if you choose to do the quantitative tasks, you'll need a protractor of some sort, either a physical old-fashioned plastic protractor or a digital one. There are many available online. Part 1. How do you perform the laryngeal ultrasound? For the laryngeal ultrasounds included in this module, we use the GE Logic E9 ultrasound machine. It's a big machine. With the 51 millimeter, 15 megahertz linear probe with a default setting of small parts. But keep in mind, you can use lots of different ultrasound machines in order to perform laryngeal ultrasounds. You can also use handheld ultrasounds, and some people prefer the little hockey stick probe as opposed to the linear probe. There are a few particularly challenging conditions to consider. The first is if you have limited access to the anterior neck. This includes situations where there's an inability to extend the neck, a C-collar or other hardware that cannot be removed, and some tracheostomy tubes dependent on the stoma location, length of neck, and size of the faceplate, though a tracheotomy is not an absolute contraindication to a laryngeal ultrasound. The second challenge can be extensive soft tissue overlying the larynx. This can include tumors, like really large goiters, or especially large body habitus, or edema, which can limit the ultrasound depth of penetration. You can try decreasing the megahertz, the frequency of your ultrasound probe. However, there will be some loss of resolution when you do so. And thirdly, calcification of the thyroid cartilage can be a challenge. Extensive calcification in older adults makes visualization of the endolarynx challenging because the ultrasound cannot penetrate through the calcification. Our data suggests, and our experience suggests, that age around 40, plus or minus 7 years, is when calcification of the thyroid cartilage starts to make laryngeal ultrasound a bit more difficult. So how do we position the patient? For infants, we lay them supine with a shoulder roll in order to access the neck. If they're particularly wiggly, a swaddle could be used to contain their arms. Usually you have a caregiver or parent help stabilize the head and soothe the baby. A pacifier or sucrose can be used as needed to help keep the baby calm. Older children can be positioned sitting in the parent's lap. A video or other distractors can be useful. However, a lot of kids do like watching the ultrasound and watching their larynx move. So where do you put the probe? The probe is placed over the cricothyroid membrane, angled slightly superiorly. The knob or little bump on the probe is usually positioned to the patient's right. Thus, when you're looking at the screen, the left vocal fold will appear on the right side of the screen, similar to looking at an X-ray or a CAT scan. We generally evaluate two conditions. One is with the baby calm or sleeping, and then we remove the pacifier in order to visualize vocalization or crying. In older children, you can just ask them to do it for you. Okay, and this is with the baby at rest. And then if we can remove the pacifier. Part 2, Interpreting the Laryngeal Ultrasound. So this is what a laryngeal ultrasound looks like. When we breathe, the vocal folds open or abduct, and when we talk, cry, or swallow, the vocal folds close or adduct. One of the easiest structures to see on laryngeal ultrasound is the thyroid cartilage. It looks a little bit like a rainbow. Superficial to the thyroid cartilage, you can see the strap muscles, which run up and down in your neck. The next easiest structure to see often are the arytenoids. You can see them as these transversely oriented structures. Next, we can see the right and left vocal folds. And finally, the anterior commissure is located at the junction of the right and left vocal folds. So how do we interpret laryngeal ultrasound? Well, there are two primary ways. The first is a qualitative interpretation. This is where you watch the video and make a determination of vocal fold movement and symmetry. This is most similar to how otolaryngologists are used to looking at flexible nasolaryngoscopy. The second is a quantitative interpretation, where you actually measure the angle between the vocal fold and the arytenoid on each side. Vocal fold movement impairment. This term is inclusive of paralysis, paresis, and mechanical fixation. Paralysis means no movement due to a neuronal etiology. Paresis means there's some movement, presumably due to a neuronal etiology. And a mechanical fixation means that the nerve is fine, but there's a reason why the joint won't move, such as scar tissue or ankylosis of the cricoarytenoid joint. Neither laryngeal ultrasound nor flexible nasolaryngoscopy can determine the etiology of a vocal fold movement impairment. Thus, the term vocal fold movement impairment is preferred over paralysis, paresis, or mechanical fixation in this module. For the quantitative evaluation of laryngeal ultrasound, still images are taken of the ultrasound in adduction, where the vocal folds are closed, and abduction, where the vocal folds are open. Then you can imagine a line drawn from the anterior commissure to the arytenoid on each side, and you measure the angle in adduction and again in abduction. In quantitative evaluation of vocal fold mobility, this is where your protractor comes in. Now, most ultrasound software has an angle measurement tool embedded within. Here you can see the right vocal fold in adduction has a vocal fold arytenoid angle of approximately 108 degrees and a left vocal fold to arytenoid angle of 102 degrees in adduction. Then you freeze the frame with the vocal folds in abduction or open and remeasure your angles. So you can see in this case, the right vocal fold in abduction has a vocal fold to arytenoid angle of approximately 145 degrees, whereas the left vocal fold didn't really budge. The vocal fold to arytenoid angle is 100 degrees. Here you can see a summary of the measurements that we took in the previous two slides. We have found that a vocal fold arytenoid angle in abduction of less than or equal to 120 degrees suggests a vocal fold movement impairment. So this particular case has a left vocal fold movement impairment. How to get the most out of these case modules. First, watch the laryngeal ultrasound video and make a qualitative diagnosis. Keep it simple. Normal versus vocal fold movement impairment. On the next slide, you'll have the opportunity to make a quantitative diagnosis by measuring the vocal fold to arytenoid angles. You will need a protractor, either a physical plastic one or a digital one that can be found online. Then reassess your diagnosis. See if it's changed from your qualitative diagnosis. Then, on the next slide, you'll have the opportunity to review the ultrasound video again, this time with our diagnosis on it, and see if you agree with us. Feel free to pause, stop, or rewind these videos as often as you need to make the diagnosis. Case 1. First, look at this laryngeal ultrasound and see if you can come up with a qualitative diagnosis. Does the movement look normal, or do you think there is a vocal fold movement impairment? Now, try to make a qualitative diagnosis. Measure the vocal fold to arytenoid angles. You can pause the video here in order to make those measurements. And now, see what your diagnosis is. Has it changed from the qualitative diagnosis? Here are our measurements of the vocal fold arytenoid angles for this case. Here is our first case once again. We think the vocal fold mobility is normal. Do you agree with us? Case 2. Case 3. Case 4. Case 5. Case 6. Case 7. Case 8. Case 9. Case 10, you're halfway there. Case 11. Case 12. Case 13. Case 14. Case 15. Case 16. Case 17. Case 18. Case 19. Last one, case 20. Thank you for participating in this module on laryngeal ultrasound for the identification of vocal fold mobility. If you have any questions about laryngeal ultrasound or about this module, please feel free to contact us.